Hi there, my name is Kerrigan Levi, and this is going to be my second SOAP note in pediatrics. Patient's name or initials is JD. I saw her on August the 29th of this year with my preceptor is Dr. Manu Bargava, who's a pediatrician, and I saw her at Pineville Children's Clinic. So, for starters, biographical data, JD is a 17-year-old white female who's been established with this clinic since she was born. She's accompanied by her mother. Both patient and parent are good historians and are a reliable source of information. Patient has United Healthcare Medicaid. Chief complaint is that she's had sinus trouble for the last 3 days. HPI, patient reports nasal congestion with drainage, headache, sinus pressure, and a sore throat that began 3 days ago. Reports decreased appetite due to decreased sense of smell and taste since yesterday. Reports she's taking over-the-counter Zyrtec since yesterday with minimal relief. Reports that other members of her class and school are sick with similar symptoms. Reports that she felt the worst yesterday and she feels like her symptoms may have started to improve today. Previous medical history, has a history of asthma, ADHD, and seizures. However, patient and mother report that she's not taking daily medications for any of these conditions. She has not had an asthma attack since she was 8 years old and is doing well in school, far with her ADHD. And she was seen by a neurologist at 10 years old to be evaluated for seizures, but no root cause was ever found. Patient had 2 seizures when she was younger and has not had any since. Patient's up to date on all vaccines. Surgical history, she's never had any kind of surgeries before. She's not allergic to any medications or food. The only medications that she's taking are birth control pills. She couldn't remember the specific birth control pill, but that is managed by her OBGYN. Social history, the patient attends a local high school in her community where she just started her senior year. She reports that she also works at a local child care facility after work. She lives at home with both parents. She's an only child, denies drug, ETOH, or tobacco use, has a small friend group of 5 girls that she's known since elementary school. Patient and mother appear to have a close relationship. Patient states that she is close with her parents and grandparents and reports that she's never had a boyfriend and is not sexually active. States that she's very driven in her goals, does not attend parties, and just recently got accepted to Northwestern State University, where she plans on becoming a registered nurse and working in labor and delivery. Family history, her mother is 45. She's living, has a history of hypertension, hyperlipidemia, and obesity. Father is 45 as well, living, hypertension, hyperlipidemia, type 2 diabetes, and obesity. Paternal grandfather is 75, living with type 2 diabetes, hyperlipidemia, hypertension, and coronary artery disease. Paternal grandmother is 73 and living, has dementia, hyperlipidemia, and hypertension. Maternal grandfather is 68, living, hypertension and hyperlipidemia. And maternal grandmother is 67, living with hypertension and hyperlipidemia. Review of symptoms. General, denies fever, chills, fatigue, changes in sleep habits, admits a decreased appetite just to lack of taste and smell. HEENT, admits mild headache and pain pressure to cheeks and upper teeth, denies head injuries, denies itchy, burning, watery eyes or blurred vision, denies ear pain, drainage, swelling, hearing loss, feeling of fullness in her ears, admits nasal drainage, congestion, denies allergies or nosebleeds or frequent sneezing, admits mild sore throat, frequent throat clearing, hoarseness, denies bleeding or swollen gums, admits pain to upper teeth, denies lumps to head or neck area. Cardiovascular, denies palpitations, dizziness, extremity swelling, syncope, shortness of breath or chest pain. Respiratory, denies shortness of breath, wheezing, dyspnea on exertion or cough. GI, denies diarrhea, constipation, abdominal pain, vomiting, reflux, nausea, bloody stools, or rectal bleeding. GU, denies frequency, urgency, hesitancy, dysuria, vaginal pain or discharge, admits regular periods, normal flow. Musculoskeletal, denies painful joints, crepitus, muscle cramps or twitching, swelling, deformities, or decreased activity tolerance. Neurologic, admits headache, denies seizures, fainting, dizziness, uncoordinated movements, or developmental delay. Endocrine, denies excessive thirst, hunger, or polyuria, denies cold intolerance. Integumentary, denies rash, dryness, or birthmarks. Objective, her vital signs, temperature was 98.9 oral, Blood pressure was 130/76. Pulse is 88. Respiratory rate is 18. O2 saturation was 97% on room air. Height is 5'3". Weight is 200 with a BMI of 35.43, which puts her in the obese category. Physical exam, general, she's dressed appropriately. She's well nourished. She's cooperative with the exam. Alert, appropriate for a developmental stage for age. She's calm. Head is normal cephalic, symmetrical. She does express pain whenever I palpate to her frontal and maxillary sinuses. Her eyes, she wears corrective lenses. Patient's eyes are round, reactive to light. Eyelashes curl up and away from the eyes. Symmetrical. Conjunctiva is pink, moist, clear drainage, no swelling, no redness. Sclera is white. Ears are symmetrical. Tympanic membrane is intact bilaterally. Pearly gray. Positive light reflex. Bony landmarks are noted. No excess cerumen. No redness of the canal. Hearing is intact. Nose, the nares are obstructed. Swelling is noted bilaterally. Mild erythema as well. Small amounts of yellowish to clear drainage. Septum is midline. Turbinates are not very well visualized due to the swelling. Throat, the hard palate, soft palate, tonsils, and uvula are all intact. Oral mucosa is pink and moist. No lesions noted to oral or buccal mucosa. Moderate erythema noted to posterior pharynx. No white patches, no swelling. Swallowing reflex intact. Teeth intact, no gum swelling. Tongue intact, pink, moist, and smooth. Neck, there's some small, palpable anterior cervical lymph nodes. They're mobile. There is a little bit of tenderness noted whenever I press on them. Integumentary, skin is pink, appropriate for ethnicity. No lesions or rashes noted. Several freckles noted. She's a redhead. Warm and dry. Respiratory, lungs clear to auscultation in all fields. Chest wall intact, symmetrical. Respirations unlabored, full, deep, and a regular rate. Cardiovascular, S1 and S2 noted. Rhythm regular, no murmurs noted. Capillary refill less than 3 seconds in all extremities. Pulses in all extremities are at a 3+, brisk. Labs, we did a CBC without diff. It was within normal limits. WBCs were 7.0. They were not elevated. No left shift noted. No elevation in eosinophils. Flu A, B, and COVID swab were all negative. My differential diagnoses are number 1, acute sinusitis, which is J01.90. Number 2, allergic rhinitis, J30.9, and viral upper respiratory infection of J06.9. Overall, my conclusion came out to be acute sinusitis of J01.90. Positive factors with acute sinusitis include that she is afebrile. She does have sinus pain and pressure that's been going on for less than 10 days. Nasal congestion, discharge. She does have a little bit of a post-nasal drip. Non-elevated WBCs or a left shift do not point to a bacterial infection. No cough. And she has known sick contacts with similar symptoms. Allergic rhinitis, positive factors include nasal congestion and discharge. Negative factors include that she does not have a history of seasonal allergies. She has no other allergic symptoms like itchy, watery eyes, or allergic shiners, or frequent sneezing. Viral upper respiratory infection. Positive factors include nasal congestion and discharge. I ruled it out due to the negative flu and COVID swabs. Of course, she could have other viral processes as well, but this is the testing that was available to us. But even so, it wouldn't change the treatment. No cough, no fever. Viral upper respiratory infection could be included due to the fact that she does have other sick contacts. But with the patient's main issue being her sinuses and the pain and discomfort with her head that she's having, that's why I chose to do acute sinusitis. So therapy, it is typically self-limiting, and we would reserve antibiotic use for persistent unimproved symptoms more than 10 days. I got that from the clinical practice guidelines by Hollier, but that's also what my preceptor said as well. So we chose to do no antibiotics right now since it's only been about 3 days. And she says that it's getting better. He did suggest, however, to do Flonase 2 sprays in each nair twice daily until the symptoms subside, just to try to help relieve some of that pressure for her. He said that she can continue to do it for up to 2 weeks. Encourage increased fluid intake. Humidified air can improve, the clearing of the mucus. Encourage analgesics like Tylenol and ibuprofen to manage headache. Teaching and counseling, we did promote hand hygiene to prevent others from getting sick. Educate on blowing the nose rather than just sucking it back up. Avoid environmental irritation such as cigarette smoke and dust. Notify PCP if symptoms get worse or if the patient develops a fever of 100.4 or higher. Referral, consultation, and collaboration and follow-up. We will have a follow-up telephone call for 2 to 3 days after to see if symptoms are improving. If they're not, according to Hollier, we would prescribe first-line antibiotic treatment with amoxicillin adult dosage since the patient is over 40 kilograms. So we would do amoxicillin 500 milligrams twice a day by mouth for 5 to 10 days, depending on the severity. Otherwise, if the symptoms go away, then the patient does have her 17-year-old wellness exam that is scheduled in a couple of weeks. We would only refer to ENT for recurrent infections or treatment-resistant infections. And in this case, the patient has no chronic conditions that would have us concerned that she would end up having recurrent infections or resistant infections. Level of billing, I put 99212, which is an established patient office visit, which is 10 to 19 minutes. Problems are self-limiting or minor. And for the CBC without diff, I did a procedure code of 85027. And all of my references came from the Clinical Practice Guidelines by Hollier. Thank you.